So we shall now go on to our next speaker, Dr. HARSHUL. No introduction, and HARSHUL is another very versatile, very innovative surgeon, and also a member ARC Central. And more importantly, I think all of us need to acknowledge that he really took life beyond ophthalmology to an entirely different level. So let's see his display of surgical skill in his video. On to you, Dr. HARSHUL.
Thank you so much, ma'am. So I'll be showing a case. This case, this patient had undergone penetrating keratoplasty, and this case had minimal astigmatism and came with this mature white cataract with posterior synechiae. So decide to go ahead and release the synechias first. So I wanted to stain the capsule well. So it's always better if you don't put OVD and make an incision away from slightly behind the at the posterior limbus, so that you don't damage the graft. You are away from the graft, and make the second side port and use a Kugelens hook to release the synechias so that I can get a better staining of the anterior capsule there. And dye can also percolate through this peripheral iodectomy, which has been done during the surgery. So I release all the synechias with the Kugelens hook, maintaining the anterior chamber with the irrigation cannula. And once I release synechia, I came out and put dye to stain anterior capsule. Can you just forward the video, please, a little bit? So here I make the main port incision, a little bit. So good staining is important. And now I wanted to expand the pupil using some of the devices. So Mulligan ring is my preferred device. This is another way I reuse the Mulligan ring. There's the cartridge of the microol lenses, which goes through 2mm incision. So it's a little bit tricky to insert the ring, especially there's a thin iris tissue which is there. So proximal scroll is a little bit tricky to insert. So I use a bimanual technique to insert the proximal scroll. So, but once this ring is in place, you can see that we get good opening there, which is maintained throughout the surgery. And I'm decompressing nucleus a little bit, making the capsular axis. I use a viscoat to protect the endothelium. Can you forward the video, please, a little bit? I go ahead and trench in the center. There's a drill and chop technique which I use in harder cataracts. I drill in the center, keep on rotating the nucleus. So drilling helps in getting a nice grip on the nucleus when you are chopping and separating the nucleus in two halves. I keep on rotating the nucleus and keep on dividing into smaller pieces. Just forward it a little bit, please. Little more. Yeah, so these are the last nuclear fragments which are coming off. Then I do bimanual irrigation aspiration, remove all the cortical matter. You can very well push the ring on one or other side to visualize nicely. And once the capsular bag is cleared, I go ahead and implant a single piece acrylic IOL in the capsular bag. So after putting the IOL, the another advantage of using these pupillary devices is you can very well visualize the exact size of the rexes. Here I realize the rex is a little bit smaller. So I go ahead to an incision with the micro scissors and enlarge the rexes to the desired size so that we have perfect centration of the IOL. It's very important that you take off all these scrolls before you try to take out the ring from the anterior chamber. So either you can use the same injector or you can just use a equivalent soap to take off this ring. And once this ring is out, case is finished. Hydro stitch all the wounds. That finishes the case. Thank you very much, ma'am.
Yeah, that was a truly a wonderful
opportunity.
Yeah, it's a wonderful video. I don't see some of our speakers here. The question which I have at this point of time is what measures would you take post-operatively to prevent posterior synechia from forming in any of these cases? Because there was posterior synechia present. So post-operatively, it could happen again. So what measure would you take?
I like to use pomade in these cases post-operatively for a few days so that we don't get, people remain mobilized.
Yes.
In post-operative period.
Dr. Anahita, I was looking for you. Can you unmute yourself because you're a cornea person? I wanted to ask you this question. Now, of course, high dose of steroids and mediatric makes sense. But besides that, there are likelihood chances of even peripheral anterior synechia forming to the graft junction. So if such a thing were to happen in this kind of a case for post-PK, how soon would you want to intervene in these cases?
So usually pass in post-PK eyes occurs when there is poor graft-host junction apposition. So if the graft-host junction has not been touched during the surgery, so usually when there is a gap that occurs, that is when the iris would go and adhere there. So if this graft-host junction is not touched intraoperatively during the separate cataract surgery, it is very unlikely that a pass will form again.
And if a pass were to form, how soon would you like to intervene and release it before it becomes too tight?
So if the pass is very minimal, less than 1 quadrant, I would not surgically intervene in these eyes. If I'm considering a secondary endothelial keratoplasty or something where I would require space in the anterior, currently with that surgery, I would do it. Otherwise, there would be no indication.
Question to the expert panel, Dr. Ajay, Ramurthy or Gaurav could answer. Since iris hooks would not be a primary choice, because as Harshul said, even our main incision, side incision, we are very particular that we keep away from the graft host junction. So we would want to make minimal incisions. But would somebody prefer an iris hook in these cases as against Malugin, especially if it is a shallow eye and you don't want to injure the graft, or would a BX ring be thought of? I want just a discussion. So any thoughts on that?
Yeah, Harshul, I think that was a very wonderfully done surgery, especially the first step when you are trying to separate those synechia and putting an infusion. That's very important, because if you put a visco there and then again it's all messed up. It's small. That was a very good idea, and especially separating and putting it, because again putting the dye. That's very important. Go behind the iris, because your staining was just in the center. It was not in the periphery. Especially this sort of eyes, the rexis might become very friable, so if you have not visibility. And the last part, Chitra asked, with the 7 millimeter in these sort of this friable irises with the 7 millimeter malignant, at the end of the surgery, I don't think you would get that. Would you do a pupilloplasty? Because I would prefer doing a hook which is just around 4.55 millimeters, because this would have gone almost 7 millimeters. And or if it is too dilated, would you do a pupilloplasty in this case because of the glare and all?
No, that was 6.25 millimeter ring which I used, and normally we use that only.
Okay. Yeah. But then even I think this was not a very hard cataract, even that Shubhen's BX would have worked probably, and hooks also
Yeah, any expander, whatever is your preferred technique. Even if you're not comfortable with
Yeah.
any expander, you can use even iris soap.
Even
So,
iris soaps.
but the
Yeah,
thing is
that
that
the point
you
was
need
that
to use the at the first
multiple,
point. So,
multiple opening could have been done. That is how a single opening one would be a better choice, as Dr. Chitra has said. But yes, if it is too shallow, definitely iris would be preferred. But otherwise, it's a very well done surgery.
Dr. Meenakshi, want to say something? Yes, Anaga?
Yeah. You were discussing about the steroids, I would feel that if post-operatively, if we have done so much of handling, if we could give just one dose of injectable 4 milligram DEXA after the 4 or 8 milligram, it substantially decreases the post-op inflammation.
Yes, Anaga?
Yeah, excellent video, Harshul. All the points were very, very well demonstrated. Did you start preoperative steroids in this patient? Preoperatively topical steroids or something?
no, I didn't.
Would that be one of the things that we can think of, because it's a PK patient plus posterior synechiae already there? Maybe there have been some episodes of recurrent iridocyclitis earlier. And like the question you asked, ma'am, for the BHEX, I would also think, I would prefer BHEX in this because it's more gentle on the pupillary edges. So I would be comfortable doing that. But anyways, this case is very well done by
Chitra, I just want to, especially when the iris and the iridectomy is little large, and that area was a little, when you put the Malucan ring, I was getting, keeping my heart in my mouth because it may tear off. BX will not tear. Malucan can tear, but BX will not tear. Iris hooks also
very
can
gentle.
Yes. Yeah, BX is probably the better option here.
No, but I've shown sir that it doesn't tear.
You
have to be gentle.
You are an expert.
You are an expert, Harshul.
You are an expert, Harshul.
It was a wonder case.
That's a theoretical. That's a theoretical complication which can occur with any device.
Yes.
So we need to believe what we see.
I actually would like to. I would agree with Harshul because this Malucan ring 6.25 version, I think it's the version 2. It's very gentle. It does seem to be a little intimidating, but it's very gentle, and I think it's the right choice as compared to iris hooks or any other device. I have no experience with the BX, but Malucan ring, though might seem intimidating, it's very gentle.
My vote is also for the Malucan ring in this case.
Yes, Dr. Ramurthy, I think that will be the last question we will take because we have many more.
Just a couple of quick observations. Most points have been discussed. Excellent surgery, Harshul. Just, the main point here is because it's a post-keratoplastic cornea, you want to be as gentle on the endothelium as possible. And having a irrigation cannula inside right in the beginning of the surgery, which is going to create a certain amount of turbulence. If you had dispersive, Ajay made a different observation. I would have put in a dispersive viscoelastic, even under which I can stain, or even used an air bubble and stained on it and used minimal amount of fluid. Again, a small observation that, your sleeve was pointing towards the corneal endothelium. And that's again something which could have been avoided sometimes if you just direct it so that it's kept away, because in this, the case was done beautifully. My only concern would be to take everything possible to avoid any injury to the endothelium.
I think, Harshul, we are just dissecting your case. It was just an amazing case.